Hello students. Today we are going to take a discussion on oral candidiasis. So it is one of the topics taken up in red and white lesions as in your syllabus. I am Dr. Saurabh Srivastava, reader in the Department of Oral Medicine and Radiology. The objectives of today's discussion are that you should be able to classify the disease at the end of the lecture, identify the disease by its clinical features, and know the local management of the disease at least. So we come on to the topic of today's discussion, oral candidiasis. Other names for this disease are oral thrush, candidosis, and the older name was moniliasis. It is one of the commonest opportunistic infections. As you know that opportunity arises for this infection, then it occurs in an individual. So the various predisposing factors we'll be taking up later on. The most common organism which is taking up this infection is Candida albicans, which is also the normal commensal flora, and it becomes a pathogen when it gets an opportunity. It affects the very young, the very old, and the very sick. These three categories of people are affected the most. It mostly affects the mucosal lining and rarely it becomes systemic. It is divided into primary and secondary infections. Primary, which are restricted to the oral and the perioral sites, and secondary, which are accompanied by some systemic mucocutaneous manifestations. Now here is the classification of primary and secondary oral candidiasis, where primary has been categorized into acute types, chronic types, and the Candida associated lesions. The secondary oral candidiasis has been associated with various systemic illnesses and categorized into familial chronic mucocutaneous types, diffuse mucocutaneous, candidiasis, endocrinopathy syndrome, mucocutaneous disease in the family, severe combined immunodeficiency, etc., and also AIDS. So we'll be discussing the disease into its etiology and pathogenesis, epidemiology, the clinical findings means the various types of candidiasis like the Pseudomembranous, Erythematous type, chronic plaque type or the Nodular Candidiasis, denture stomatitis, angular cheilitis, median Rhomboid Glossitis, and the Candida associated with HIV infections. Along with it, we'll come to the investigations and the management part of oral candidiasis. So starting with the etiology and pathogenesis, it has been seen that Candida albicans, Candida tropicalis, and Candida glabrata, these three categories of organisms or the fungi, they comprise together almost about 80% of human candidal infections. So how it happens? So to invade the mucosal lining, the microorganism, means the fungus, it must adhere to the epithelial surface. So because epithelium, it sheds itself after a particular amount of time, so it should have the capacity of adhering to the surface. So candidal strains which have better adhesion potential are more virulent than the strains with poor capability of adhesion. So it all depends upon some of the predisposing factors which will help the candidal organisms to adhere to the tissue. So these predisposing factors can be categorized into local factors and the general factors. The local factors are denture wearing, smoking, atopic constitution of the tissue, inhalational steroids, topical steroids, hyperkeratosis. Steroids, when they are used on long term, may lead to such infections. Hyperkeratosis, imbalance of the oral microflora, the quality and quantity of salivation will also affect the tissue. General factors can be the immunosuppressive diseases which are present in the body, impaired health status, immunosuppressive drugs, chemotherapy, endocrine disorders, and hematinic deficiencies in the blood. These may predispose the body to getting candidal infections. Then local predisposing factors, they promote the growth of the yeast and to affect the immune response of the oral mucosa. The general predisposing factors related to an individual's immune status and the endocrine status. Then epidemiological aspect of oral candidiasis can be seen as this prevalence of the strains have average figure of 35%, which has been calculated from various studies which have been done on the patients, and it has been frequently isolated from women and increase in the months of summer. In various hospitalized patients, it is very commonly seen, and in the prevalence of denture stomatitis with the candidal infections has been seen in a variable range of 11 to 67% of the patients. So it is very common, that means, because 67% has been seen. Now coming to pseudomembranous type of candidiasis, as the name suggests, there is a false membrane which is present over the infected area. So this is the classical candidal infections, also seen in majority of patients and seen as a whitish curd-like appearance. So the presentations of acute and chronic pseudomembranous are almost similar. These have loosely attached membranes, which are pseudomembranes or false membranes, and these comprise mainly of fungal organisms and the cellular debris. And upon scraping this membrane, it leaves an inflamed and sometimes a bleeding area. So this is the very characteristic diagnostic test for pseudomembranous type of candidiasis, that upon scraping up of the membrane, there is an erythematous or bleeding area which is left at the site. Less pronounced infections, which are sometimes clinical features that are difficult to discriminate from food debris like egg and yogurt. So it mimics that appearance. So these are some of the pictures which have been seen in patients where a pseudomembranous type of appearance of the disease is seen, where you can see whitish thick plaque-like substance which is deposited on the oral tissues. In the first picture it shows the lower lip, then on the tongue also it appears somewhat curdy or fluffy type of material which can be scraped off. It appears like that. If we try to scrape it off, it will be coming out of the tissue, leaving an erythematous area. And amongst the tissue or the lesion, you will also see some reddish or deep erythematous areas. Now another picture which is showing a typical thrush in the oral cavity in the posterior part of the oropharynx, which involves the soft palate, a part of the hard palate, even the pharyngeal mucosa. Usually such type of picture with an intense erythematous mucosa will be seen in patients who are actually immunocompromised. This is one of the histopathological pictures of the photomicrographs which shows the candidal hyphae. You can see thin tube-like structures or lines in between the or over the picture which are magenta in color, and you can see these lines which are actually the hyphae of Candida. These hyphae itself, they embed into the tissue of the host. These steroids which are used as inhalers or topically when they are used, they will produce a pseudomembranous lesion which is of chronic nature, and some discomfort may be experienced from the presence of these pseudomembranes. Then erythematous type of candidiasis, it was previously referred as atrophic oral candidiasis. However, an erythematous area may not just reflect atrophy but can also be explained by increased vascularization. So both the things are possible. The lesion in this type of candidiasis has a diffuse border which helps in distinguishing it from erythroplakia. So the differential of erythematous type of candidiasis will be made with erythroplakia, which usually has a sharper demarcation and often appears as slightly submerged lesion. So if we have a reddish area which is very sharply demarcated, we'll call it as erythroplakia rather than an erythematous type of candidiasis. The erythematous candidiasis, it can be considered a successor to pseudomembranous type. So whenever we see pseudomembranous type of candidiasis, we can also suspect that in subsequent time it may convert to erythematous type. So this is one of the pictures where the palatal mucosa is showing a reddish area which is having diffuse borders, not very sharply demarcated, And this erythematous area is associated with some habit of either steroid intake or any other habit which locally irritates the tissue and causes the opportunistic infection to occur in the oral mucosa. So this is another picture of the palatal mucosa only, which is showing very diffuse borders and slight changes in the palatal tissue, as also in the category of erythematous type of candidiasis. This infection is predominantly seen in the palate and dorsum of the tongue of patients who are using inhalational steroids. So we can say that patients who are having steroid therapy or who are having inhalational steroids due to some respiratory problems, they are more suspicious of having this type of candidiasis, and in the long run they may develop such candidiasis. So certain precautions are being told to such patients who are taking inhalational steroids, like swishing of the mouth or rinsing of the mouth with some antiseptic or plain water after use of the steroids. Then some other predisposing factors that can cause erythematous candidiasis are smoking and treatment with some broad spectrum antibiotic agents. And in this also, the acute and the chronic forms, they will usually have the similar clinical features. Then we come to the chronic plaque type and the nodular type of candidiasis. These plaque type, it replaces the old term candida leukoplakia or hyperplastic candidiasis, where now we say it as chronic plaque type of candidiasis. And in this type of candidiasis, the lesion or the tissue which develops as a result of infection cannot be scraped. This type of candidiasis, we cannot scrape the lesion. So over here, a white irremovable plaque is characterizing the typical clinical presentation, or there will be an irremovable, unscrapable plaque which is present, and it cannot be distinguished easily from oral leukoplakia. So we can see the lesion on the buccal mucosa, where reddish component and erythematous area is present on the buccal mucosa, over which some plaque-like lesion, whitish plaque-like lesion is present in between the reddish component or the erythematous areas, and over the or anteriorly near the commissural area, we can see small nodular appearance of the lesion. So it is having the nodular as well as the plaque-like and the erythematous component of candidiasis. Here another picture which is showing actually the nodular appearance as well as the plaque type of candidiasis. Another picture which is showing the ventral and the lateral surface of the tongue and the floor of mouth, which is being infected with the opportunistic candida, and it is also appearing like a plaque all over the surface with some erythematous areas. So we see that there is a positive correlation with oral candidiasis and somewhat epithelial dysplasia. So whenever we are having such a lesion, we should check for the dysplastic changes under the microscope. So both these plaque type and the nodular type have been associated with malignant transformation, meaning thereby if we see such a tissue, we should take it for biopsy and rule out any malignant changes, and also keep the tissue under follow-up, keep the patient under follow-up. So the role of these fungal agents or fungi in oral carcinogenesis is still unclear, but it has been said that there is a capacity to catalyze the nitrosamine production by these fungal agents, which nitrosamine in turn will cause the malignant changes or conversion to malignancy. Then we come to candida associated lesions, means where there is a lesion due to some other thing and the candida has grown in that. The first one and the commonest is the denture stomatitis. It is mainly seen in the denture bearing area and is classified into three types. Type 1 is limited to minor erythematous sites caused by trauma from the denture. Type 2 is the major part of the denture which is covered by the mucosa. And type 3, it is having the type 2 features along with a granular appearance of the mucosa. So we can see in this picture that there is an erythematous area which is well defining the denture base. We know what type of denture base is given in an RPD, which type of denture base is given in complete denture. So this picture will certainly tell us that an RPD was borne by the patient, and the patient did not take out that RPD and gave the candidal hyphae to penetrate into the tissue. So if the denture wearing is very prolonged and denture cleaning is not done properly, then such type of infections, they can occur with the use of RPDs and CVs. Here we can see a picture of complete denture here, a patient where the palatal tissue is showing some granular changes along with erythematous area all throughout the palate. That means all throughout the denture bearing area. This will be categorized into type 3 denture stomatitis. When we come to angular cheilitis, it is seen as infected fissure of the commissure of the mouth, often bilaterally, and surrounded by erythema. The lesions are frequently co-infected with both Candida and the Staphylococcus aureus. Vitamin B12 deficiency, iron deficiency, and the loss of vertical dimension, they have been associated with this disorder. Now we can see in this picture that at the corner of the mouth, it is appearing slightly wet, and fissures are seen at the corner of the mouth or the commissural area, which is wet as well as slightly crusted in that area. This is the typical appearance of angular cheilitis. This is on one side. In another picture, we can see it on both the sides. This folding of the corner of the mouth or forming of fissures in the corner of the mouth causes drooling of saliva or wetting of this area by the saliva, and this wetting of the area by the saliva will cause more and more growth of Candida and the bacteria, because both the things will be growing more on the wet tissues rather than the dry ones. Now, atopy also has been associated with the formation of angular cheilitis, and dry skin may promote the development of fissures. And after the development of fissures, these invasion organisms, they invade the tissue, and the salivary wetting also occurs in these fissures. Now, 30% of patients with denture stomatitis also have angular cheilitis, but this infection is only seen in 10% of denture wearing patients without denture stomatitis. So many a times it is seen that while fabrication of a denture, there is a step of measurement of the vertical dimensions of the teeth. So it is a very important step where we measure the vertical dimension of the teeth or the artificial teeth which are to be placed inside the mouth. If the vertical dimension is less, then what happens? Upon closure of the mouth, there will be a fissure or folding of the angles of the cheek, or the corner of the mouth will be folded, the tissue will be folded, and in such folds of tissue, angular cheilitis is more commonly developed, and hence candidal infection also. Then we come to median rhomboid glossitis. It is characterized by erythematous lesion in the center of the posterior part of dorsum of the tongue. As the name suggests, median rhomboid is the shape, and glossitis. So it has an oval configuration, and the area of erythema, it results from atrophy of the filiform papilla, and the surface of the tongue may be lobulated also. So in this case also, various etiologies have been suggested, and some biopsies have yielded that candidal hyphae are present in more than 85% of the lesions. So Candida has been strongly associated with median rhomboid glossitis. This is one picture where we can see at the posterior dorsum of the tongue, we can see a very well defined atrophic area or depapillated area in the center, and it is round, it is more of an overt type of appearance. Another picture showing a similar lesion which is also present in the posterior part of the tongue on the dorsal surface, and again appearing depapillated and ovoid in size and shape. It is usually seen in smokers, denture wearers, and patients using inhalational steroids. So these are the high-risk patients, and sometimes a concurrent erythematous lesion may be seen on the palatal mucosa. When a median rhomboid glossitis is seen on the tongue, there may be a similar erythematous lesion on the palatal mucosa. So these two lesions are then called as kissing lesions. It is the terminology given to these lesions because on closure of the mouth these two lesions come in contact, and may be a possibility. So asymptomatic, it is usually asymptomatic, and the management is restricted to reduction of the predisposing factors only. Now the oral candidiasis associated with HIV. In more than 90% of the patients with AIDS, they have had oral candidiasis during the course of their infection, and this infection is considered as a potent means an indicator of AIDS development. So if a person is infected with HIV and develops candidiasis, it indicates that the person will progress to the development of full-blown AIDS. The most common types of HIV are pseudomembranous, or the most common types of candidiasis associated with HIV are pseudomembranous type, erythematous type, angular cheilitis, and chronic plaque-like candidiasis. So this also occurs as a result of highly active antiretroviral therapy, or HART, where the prevalence of oral candidiasis has decreased. So if the HIV patients are treated with HART, then oral candidiasis is less likely to occur. This is a picture where we can see there is a central depapillation over the dorsal surface of the tongue, over the right lateral surface of the tongue, with some whitish component, and the foliate papillae on the lateral surface of the tongue are also showing some whitish component. The whitish component which is present on the lateral surface of the tongue with slight fissures is the foliate papilla, and these papilla, when develop whitish appearance, they will give the appearance of a hairy tongue or hairy leukoplakia, which is commonly associated with HIV. Then we come to secondary candidiasis, or the candidiasis which is associated with the systemic illnesses. It is due to the systemic illnesses and other immune deficiencies. The chronic mucocutaneous type of candidiasis, it is having a heterogeneous group of disorders which apart from having oral candidiasis may also have skin disease, typically at the nail bed, and other mucosal linings such as the genital mucosa. The face and scalp also may be involved, and certain granulomatous masses are seen at these sites. It may also involve the tongue, and white plaque-like lesions are seen in conjunction with some fissure development. So chronic mucocutaneous candidiasis can occur as a part of endocrine disorders including hypoparathyroidism and Addison's disease. Shediac-Higashi syndrome is also showing some parts or features of the candidal infection, where in this syndrome there is impaired number of neutrophilic granulocytes. So immunocompromised status of the patient is present, and severe combined immunodeficiency syndrome, where the cell-mediated immunity, it is defective, and there is frequent contract of disseminated candidal infections. It is more rare, and I would say it is more severe infection because it is disseminated throughout the body. Then thymoma, which is a neoplasm of the thymic epithelial cells, also has some features of systemic candidiasis, where another Now coming to investigations, we can say that candidal microorganisms are present as non-commensal microflora in the oral cavity, so it is difficult to discriminate the normal state from infectious state of the candida. So it is imperative that both the clinical findings and laboratory data should be balanced and matched in order to arrive at a correct diagnosis of the disease. For this purpose, there are several methods to take up the investigations for candidal culture specifically. First is the smear, where scraping and smearing is directly done onto the slide. Then swab is taken by rubbing the cotton-tipped swabs over the lesional tissue. Imprint culture is done by plastic foam pads which are dipped in Saurabh agar or in broth, placed onto the lesion for 60 seconds, and it is pressed on the agar plate and incubated for the colonies to be counted. Then impression culture is there, where maxillary mandibular alginate impressions are taken, casted in agar fortified with Saurabh broth and incubated. Now salivary culture is done by taking 2 ml of saliva into a sterile container, vibration and culture on Saurabh agar by spiral plating and counting of the colonies. Then oral rinse is done by subjecting the patient to rinsing for 60 seconds with phosphate buffer saline at pH of 7.2 and returning it to the original container. Then concentrated by centrifugation and cultured and counted as the previous methods by colony counting. So all these methods, they have been done for making and counting colonies of the this candidal species or candida, and based on these numbers pertaining to the candidal colonies, that is the colony forming units, if they are up to 400, then we can say that the candida which is present in the oral cavity is pathogenic. Then we move on to the management of oral candidiasis. So the various fungal infections, they are managed with antifungal regimes. They will not be always successful unless the predisposing factors are addressed. As we had talked previously about the predisposing factors for the candidal infections, the local factors, they are easy to identify, but sometimes all the factors are not easily reduced or eradicated. And antifungal drugs which have a primary role, the antifungal drugs have a primary role in such cases, and most commonly used drugs belong to the groups of polyenes or azoles. Here is a tabular representation of various drugs, their forms, dosages, and the comments or interactions or various side effects which are produced by these drugs. As we all know that polyenes or azoles which are present as antifungal agents, they are not non-specific agents which are acting in the system or the body, non-specific for the fungal cells, but they are also active for the tissue or the host cells. So as much damage they do to the cytoplasmic membrane of the fungal cells, they are damaging the cell membrane of the host also. So they are having more and more side effects when taken systemically. So amongst the drugs we have amphotericin B, which is available as lozenge and oral suspension, nystatin available as a cream, pastil or oral suspension, clotrimazole available as a cream and solution, miconazole which is available as oral gel and cream, ketoconazole available as tablets, fluconazole as capsules, itraconazole as capsules. So these can be given systemically for a limited period and with keeping in mind the various side effects which they can cause. Here is a representation of the decision of making medicinal treatment by what route. If we are presenting the patient with oral candidiasis only, so and we can rectify the underlying cause, even if there is systemic candidiasis and rectification of the underlying cause is possible, either locally or systemically, then we can go for parental route of the medicine, which is amphotericin B. If the rectification is possible, not possible, as in AIDS or diabetes, then we have to seek the physician's opinion. We cannot move forward with the treatment protocol. And if the rectification is possible, then we can go for a topical route, as in case of denture stomatitis, angular cheilitis, median rhomboid glossitis, by giving clotrimazole gel, cream, or solution. Nystatin tablets can be given to crush and mix with water and used as a mouth rinse. Fluconazole dispersible tablets can be used with water. Then, if the oral route is there, we are giving the medicine by oral route, as in case of pseudomembranous or hyperplastic and acute atrophic candidiasis. We can give fluconazole tablets 150 mg, 200 mg, ketoconazole tablets, itraconazole tablets. So all these management tools we have depending upon the situation or the type of response which we achieve from the candidal infection and the medicine. So, to summarize this topic, I would say that the various types of candidal infections which are presenting in the patient at the time of examination and case history, along with the predisposing factors which we come across, we can seek the local and the systemic predisposing factors with the patient's history only, and based upon that clinical features we have the management along with the investigations, whatever investigations we are doing, the most common being the smear preparation and cytological examination for candidal hyphae, which is most commonly done, and quite a time it proves to be correct and confirmatory. So the management will depend upon the type of medicine and antifungal agent. Primarily, we start with the removal of the predisposing factors, and then topical application. If the patient is not relieved with the topical application, then we only go for the systemic treatment. So with this, we can finish this topic today, and I'm most welcome. You are most welcome with your queries, and thank you for now.